All right, so yes, this is a big day. This is a big day, April 24th, 2023. Put it on your calendars, y'all, because this is our QIP kickoff. That's my Molly Shannon impersonation. Anyways, okay, I'm gonna hand it off. Well, first, let's say a couple of words of welcome. Michael, just so you know, I told Oscar to maybe tag team with you. He was having some trouble with the link. But I do want to say just some words of welcome on behalf of myself, Oscar, Angie, Regina, D'Angelo, Michael, and Octavio, and the CQM team. We want to welcome you to our 2023 QIP Centered on Linkage to Care, the kickoff webinar. So we're actually I'm going to hand it over to Octavio, and he's going to start sharing the screen, and we're going to go ahead and get started.
Good morning. Can everyone see the slide?
Yeah, looking good, sounding good, brother.
Awesome.
Oh, you're muted, Octavio.
Okay, so do you want me to get started? So
Yeah. No, go ahead. That's fine.
So good morning, everyone. We want to offer a special extended welcome to the area partners, such as our ATC network colleagues, DHSS, and other aid staff. And also we'd like to show our enthusiasm for this next regional QIP and linkage to care, or L2C. So now we would like to offer Sonia the opportunity for some words of welcome, please. Sonia, are you with us?
I don't think Sonia's here, but we can go ahead and just roll into the Zoom reminders. And if folks could maybe tag their agency after their name, or if you're AETC, or if you're Dishes, we could do that. And I think this is maybe Angie. Go for it.
Good morning. Excuse me. Good morning. Yeah, as we review our Zoom features, as Jamie said, just go ahead and drop your name and organization and your favorite springtime activity into the chat room. Hopefully, hopefully it feels like springtime wherever you are. It does not here in Texas at the moment. It certainly didn't yesterday, but hopefully everybody will begin to feel some warmth and lack of hail and tornadoes and things soon. So just as a reminder, go ahead and press escape, if you need to exit the full screen. Hover over the top right to change your view options. Place yourself on mute until you're ready to speak. We love for you to use your webcams, but we understand if spring's got your eyes watery and swollen or something else is going on and you're not able to do that, we fully understand. Use the chat room to interact with us. And just remember, this meeting is being recorded and will be available for sharing along with other items in our toolkit for this meeting. Next slide, please. So by the end of today's webinar, we hope you'll be able to describe the expectations for the year related to linkage to care at the subrecipient and AA level, discuss how linkage to care can solidify Rapid Start in Dallas, gain knowledge of additional Rapid Start efforts across Texas, explore measurement through guided breakout discussions, and understand concrete next steps leading to our next webinar in June. Next slide, please. So here's our toolkit from today's meeting. It will include today's slides, the action planning form, our root cause analysis form, or a driver diagram, fishbone diagram, and 5 whys, AIM statement template, PDSA form, and Rapid Start literature. At this point, multiple tools have been shared with everybody. We've gone over several during our ACC, our external CQM committee meetings. Some of you may be really familiar with some of those. Some may be familiar with others. It's just important that when you do your RCA with your team, that you use something that you're comfortable with. And then remember that we're here to help you all. So please reach out if you need any assistance. And I think I'm handing it over to Jamie now.
Awesome. All right. So we want to set some QIP expectations. What are we doing this year, right? Go ahead. We can advance to the next slide. So again, folks, this is going to look and feel familiar for everyone who participated in our previous QI project, Return to Care. We're going to follow this similar cadence, right? So we've got our month and our year, and we're going to have these QIP webinars for capacity building and resource sharing. We're starting today. April is our kickoff month each year, and then we'll also have one again in June, August, and October. We culminate once more into a World AIDS Day poster symposium. So let's think about this. Last year we did the first one. Yeah, thanks, Octavio. And this sort of cadence follows our discovery, root cause, and implementation. So right now we wouldn't expect anybody to be ready for implementation, right? This is kind of the overall arc and trajectory, and it'll culminate once again in every agency creating their own storyboard to showcase at a World AIDS Day event there in early December 2023. One thing we want to keep in mind is, there's stuff that happens in between these webinars. So we call those action periods. And Angie's done a great job creating action plan templates to assist you in just identifying after each of these webinars, what are the concrete steps? And even for our partners at the AETC or other individuals in the AA or even dishes, right? Maybe there's some concrete steps you guys want to take after this to promote leverage and learning. Next slide. All right, so part of the expectations, what are things due? We've worked hard to meet with all of the subrecipients over the last 2 weeks in advance of this. And one of the things we wanted to do, again, in support of customer service is to collapse some of these reporting periods, make things the same date, and make be less forms. So the first due date for anything related to your QIP is June 15th. So you've got about 6 weeks, right? We have this root cause analysis form, and that's something where you'll share what did you and your individual agency team do within your QI project to identify root causes. You have the PDSA worksheet, which is familiar to everybody. That's the Word document that walks us through the discrete PDSA test of change. And Angie has zhushed this baby up for you all. It's got some embedded drop-down menus to actually equate to less typing for you and just easier streamlined work. And then, of course, like I mentioned just a second ago, with every one of these webinars, we have action plans. So your due dates are going to coincide with reporting any QIP metrics, with reporting of your performance measures. So again, we're looking at June 15th, September 15th, and December 15th. We do know, though, right, that World AIDS Day happens before that. So the poster symposium, we're probably going to go around 2 weeks beforehand, which would be November 17th. But once again, the AA is going to provide your storyboard template, give you time to work on it. We ask for that 2-week window so that it can come back. We can provide feedback if there's some additional formatting, beautifying of the document. You don't have to be a wizard in formatting. We're there to assist, okay? So just keep in mind that that will be mid-November. We can go to the next slide.
Hey, Jamie, I just want to jump in real fast because you'll hear you'll hear later in the presentation, everyone, that the PDSA worksheet really is about helping to champion your work and describe your work as you go. And you already know this, but since we're starting a new project and we're submitting the root cause analysis form at the same time, we're not expecting you to have a complete cycle of change completed in June. What we're looking for is for you to begin the planning for what your first tests of change will be, and to populate especially that P phase. But you'll hear more about this. We just wanted to make sure that, on this slide, you weren't getting the sense that you had to have all of this front loading done at work and a test of change done, because that wouldn't be reasonable.
Yeah, thank you, Michael. All right, so we've talked a little bit about expectations, and honestly, so much of that is, what we've been kind of in the rhythm of doing. But let's talk about where we are to date. You can go to the next slide. So we as a jurisdiction, we have looked at our Linkage to Care QIP project, and we've looked at it again in these 3 QIP lifecycle phases. Everything we do boils down to one of these 3 phases. We have discovery, root cause analysis, which helps you identify your test of change ideas, and then implementation. So again, we're all in sort of a planning phase. During discovery, we assess what relevant data, right, whether it's quantitative, qualitative, what other key factors, like key initiatives are happening. And we can go to the next slide. We'll actually walk through some of this together. So over the last, I don't know, 3 or 4 months, we've been doing some discovery. So what's the current situation in Dallas? We know that we've had quantitative data challenges because of changes and switching over to E2 and also the state switching over to TCT. So what does that mean? It's meant we've been really reliant on agency level data systems, right? But we have a lot of qualitative data, and actually a majority of our CQM performance measurement is qualitative. Plus, we've got some exciting things going on with the stakeholder experience evaluation, C. We've also can leverage things like the status neutral needs assessment and psychometric testing focus groups. So we are qualitatively rich, y'all. We also know that many folks have started Rapid Start, started implementing that to certain degrees within their agency, or asked questions and clarifications. You know, is my clinic doing it sort of like with the vision that the jurisdiction has, and things like that. We also talked with Return to Care a lot about medical neighborhood. And so that's one of those like key factors that we want to bring into our discovery process. How do we partner across agencies, whether they're in our Ryan White network or not? How do we partner across divisions in our own organizations? You know, you work on that sort of medical neighborhood in your own organization and then spread from there out. And then we definitely have an interest in disparities. So this is also part of our discovery. Disparity analysis has been a goal for us at the AA at the recipient level, and actually HRSA completed a site visit last week, and that's also something in the exit interview that they put as an expectation for us to explore. So that's sort of part of the larger discovery. We can go to the next slide. These are our various discovery resources, right? So we talked a little bit about the status neutral needs assessment. We also know part of our discovery would be looking at different things like different resources. So some folks use the continued tablets with Return to Care. And we still have those left, right? So there's an opportunity to repurpose or think about how can we use continued tablets with this QIP linkage to care. This is going to be useful for our testing staff, for the staff who makes referrals with people. Would they want to meet with the patient, you know, at time of diagnosis? And maybe that's less invasive, you know, I don't know. But the continued tablets remain a resource for us. Again, we talked about the quantitative data from your subrecipient EMRs and internal systems. We also know that Dishes is doing maybe not like their first ever statewide QIP, but definitely hitting a refresh on that statewide QIP project. And as I mentioned, other forms of qualitative feedback. Next slide. So I know we have Julie Saber here from Dishes, and Julie, I don't want to put you on the spot, but I want to welcome, if you want to say a moment, if you want to say a few things about the statewide linkage project, if you want to talk about that, I'll come on off mute and I'll give you the floor if you want.
Absolutely. Always excited to promote our statewide project and super excited to see that you guys are in alignment with what we're hoping for. We want everyone in the state to really ramp up their efforts around linkage to care. We know there's some amazing work that's already going on. So y'all that are already on it, just keep what you're doing. Those of you who may need a little more technical assistance, guidance, or capacity building, we are going to learn from the peers that are doing the great work and share what they're doing with all of you, as well as leverage our AETC to help us with another Rapid Start Institute this summer. And we're going to collect all the different projects that are going on around the state and then share them with everybody so we can learn from each other. We have all of our Ryan White AAs as our first phase of the project, and then we're hoping to extend out beyond our circle of influence or the people we fund, right? Because we need everybody's participation to actually make this work. I have a lot of specifics about the project, but that's just a really high level overview for now. If anyone has any questions, I think everyone knows how to reach me. But if not, just reach out to the Dallas AA. They know my phone number and email address. Thank you.
Yeah, we got you on speed dial, girl. Yes, but thank you, Julie. It really means a lot. We're really lucky that we have your support, and we want to welcome other folks from the state. Thank you for joining this call as well. So we can go, just so you know, our QIP is kind of nesting, like Julie said, within this larger statewide effort. So one thing we hear from folks a lot is alignment, less is more. And so this is part of that effort. We can go to the next slide. And Julie, again, I'll share a little bit, and then, if there's something you want to add, go for it. But in terms of, Texas doing a statewide linkage project, they have really done a fabulous job setting up some different structures. Like you see that image on the left, that's going to be the Texas statewide project charter for this QIP project. And that's trickled down to all the AAs. So for example, the red one that you see on the right, this is going to be our Dallas County Dallas AA project charter. And this is actually something that Oscar will be doing and working with the CQM team, but he'll be sending this off, I believe it's due April 28th. So it's important for you all to know that when you fill out your PDSA form, when you're sharing what have we figured out during our root cause analysis and discovery, that information matters very much. It matters because it informs how we do these webinars and what we talk about. It informs what we understand from our jurisdiction, and then it informs what rolls up to the state. So there are definitely dedicated intervals this year where your particular information helps us in terms of meeting a state expectation of sharing and documenting, the same expectations we have of you are ahead of us as well. So that's something that's different. That wasn't the case with Return to Care. So I just want to give you all a nod that your work is never, ever done in vain. And it's really essential. We can go to the next slide.
Just really quick, I'd like to share that our upper management, the whole division is looking at linkage to care. So your work is totally getting recognized by some of the top leaders at the Texas Health State Department. This is a statewide initiative beyond just a quality improvement project, as well as working on viral suppression, which of course we need retention in the middle of all that. But I just wanted to let you know how important this is to the leadership at our state. But of course, it's most important to us because we're so passionate about people living with HIV and giving them the best quality care in the quickest time possible that works for them in our systems of care. But thank you again.
Thank you, Julie. So we talked about the QIP life cycle, right? There's always discovery, then comes root cause analysis, which informs your change ideas. So we looked at our discovery pieces. Part of that is a huge influence from the state. What about our root cause analysis? So if folks remember, so if anyone participates in the ECC meetings, this is something we did. Folks, I got to remind you, thank you for muting yourselves. This is something we did where we're looking at linking newly diagnosed for the testing sites, looking at linking the newly diagnosed with the dual bacterial STI 7 days from diagnosis, right? So this is our chance to also stand up rapid start. So we used a fishbone diagram, but we walked through this root cause analysis activity where folks such as yourself in the ECC meeting generated individual barriers, right? What are the things that are keeping us from getting that linkage in 7 days? And that's what you see on those individualized Post-its. And then we kind of cluster common themes, and then we name, one of those branches or one of those fish bones. So this is an example when we talk about root cause analysis of something that you at your individual agency would do with your clinical team. Next slide, please. So now I want to hand it over. We've talked about our jurisdictional journey through discovery and root cause analysis. And now I want to kind of hand it over to our colleague OP, Octavio Posado, to talk about how this linkage project actually helps us put some real meat to rapid start, specifically in Texas and Dallas. Go ahead, OP.
Thank you, Jamie. And good morning. My name is Octavio Posada. I'm the newest member of the OE team. I am the EHE CQM consultant. Back in Vegas, we call it EHE. It's interesting how different places call EHE differently. So as Jamie mentioned, I'm here to get you guys excited about continuing the work and looking at rapid start in Dallas and exploring how that will look like. So here we're looking at what's the current CQM contract with the county and how we can expand to include those outside of line-wide network. We have, for instance, a non-line-wide funded agency that was part of the learning collaborative for the rapid start in Vegas. So it can happen, it does happen. It's really a matter of coordination. And also looking at our 2023 linkage to care QIP that would allow us to think about more than right and white interactions. And then the linkage to care as a way for us to look at rapid start as it's happening in small practices, right? It's going to vary from agency to agency. And then, we will work on bringing folks like myself to, and then with the collaboration of Frank Thompson, who's part of the leadership coaching across networks, and also integrating EE funded subrecipients into our L2C project throughout this program year. And also the OE contest will hold the county that goes to February 2025, which means that you'll see the efforts to continue to grow and how L2C or linkage to care will advance rapid start in Dallas, which would also align with the state's linkage project and would allow us to expand beyond our typical networks and funding silos. And I will now hand it over to Michael.
All right. So as we're talking, there are so many synergies to keep in mind here, and our nesting dolls really are designed to help further the great work and to alleviate burden. We know that a lot of attention and focus can be a great thing, but we also know that that attention focus can read as a bunch of flies buzzing around your head, and you'd like for them to just be a little bit more ordered. So we've put a lot of planning and thinking into this. And of course, we're always open to feedback and critical feedback as we work our way through. But, as we've already mentioned a couple of times, this activity is happening alongside the Rapid Start Institute. So we have our 4 South Central AATCs that are located in Texas. We have, folks that are local to the Dallas area at PRISM. We have folks in Baylor, in Houston, at University Hospital in San Antonio, and the Valley AIDS Council in the Rio Grande Valley. And they've been working for several years to put together this Rapid Start Institute. They already have 2 learning sessions that have been completed, and they're working on creating a website that basically will create a place for you to go. There's stuff for clinicians, there's stuff for social service providers, and there's stuff for finance and compliance administrative folks in the middle. We will be planning a 3rd session for the summer, and we're hopeful that it will be a session that most of us will be able to attend in person, centrally in the state. And again, the project that we're kicking off today, as Julie and Jamie mentioned, is also in place in all other areas of the state, but they may have a slightly different face. So this, Rapid Start Institute would be an opportunity in the summer to come together and to share progress with other people who are providers implementing on the ground. And there'll be a lot more information about that to come. We're really trying to plan this in a way that is engaging to key personnel at each of our different types of sites. And we think that it'll be a great opportunity. There is a Rapid Start Learning Collaborative that EHE in our administrative agency in Dallas has signed up to join. I don't know, Miranda, if you want to talk a little bit about this, this is distinct from, some of you may be aware that we are planning a Rapid Start Learning Collaborative that's more broad, that's several years, that'll involve the county jail, the emergency departments, and a couple other settings. So that's separate. But Miranda, I don't know if you want to talk about this small one with NACCHO and CAI.
Yeah, I just wanted to say that one of the big things we're focusing on, and we'll get further into it, but just to start to put that tingle in the ear, we have some flexibility with EHE that we like to be able to build into our larger system. And so in talking, and I know Octavio's done a lot of work with this in Nevada, but in talking, we're really wanting to use the next year and some of these conversations and the takeaways from this QI project to really formalize ways that our teams can work together. And I won't get further than that, but it's really exciting stuff and just very grateful to be a part of this process. Thanks, Michael.
Hey, thanks, Miranda. All right, and there's one more thing to note that our partners on the other side of the airport there in Tarrant County and in their multi-county region are also working on putting together an internal learning collaborative focus on Rapid Start. So that piece that I was discussing with emergency departments and jails, guess what? They're going to do something similar on the other side of the airport, and we're going to have opportunities to, in the next couple of years, to compare notes. So think about this as two big arms. We have our Ryan White and EHE Linkage to Care project that's really focused on PCN 1602 categories. And as we work outside of the Ryan White network with our other large areas that are funded, we'll think about how they can talk to us and kind of work with us on linkage to care. And then the Rapid Start piece that's in hospitals and jails, all of us working together in civil society and broader clinical service to achieve a regionalized Rapid Start definition and a solid linkage to care process. So this is not something happening in a vacuum at all. And it is actually part of what we would like to view as a meta collaborative process. And it really is an opportunity for us to spread learning and to generate that system of profound knowledge that you've heard us discuss a couple years now. So let me see if I can, let's move to the next slide. I'm like, why can't I move to the next slide? There's a reason. Oh, go ahead, Jamie.
Well, I just want to add, so what does all that mean? It means like when you encounter like an obstacle or a plateau, reach out, ask questions, because we can pull beyond our AA funded jurisdiction. If you're a support agency, because you know what, fact is, that's a smaller number than our OAHS, right? This allows us an unprecedented level to tap into other only support service funded sites, right? So it's really great, all of the different Rapid Start activities and linkage focused activities. And that just means there's more wealth to share. So, don't be a stranger. Thanks, Michael.
Completely. A plug for those special relationships that we have. Like if we're part of the funded network, but we work a lot with unfunded groups, that's something that we can examine across the entire state and bring people together. That's so important. So just again, to summarize, not to hit, the horse here until it is long dead, but we're allowing the county to concretize and streamline what is Rapid Start here. Some of us have been applying Rapid Start in different capacities and definitions, as we've discussed in ECC over the course of the last several months, 6 months. So what we're trying to do is just to have one single definition. And if there's caveats and carve outs within that definition, let's name those. Okay. So the organizational empowerment expansion really brings together this Rapid Start expertise. So, you've been hearing from me and Jamie for a while now, but really thinking about Octavio Posada's expertise, Frank Thompson's expertise, and how that's going to help us to leverage relationship building, reporting, and the conversational pieces that are just really important to our work. Really, all these efforts are coming together to capitalize on our energy and to leverage our learning and to leverage the opportunity for collaboration as we move forward. As we've all noted, this is a very carefully planned activity, thinking about these different moving pieces. So we're going to be really interested, as I said before, in your feedback, including your critical feedback, as we work our way through to see what we can do year to year to continue making our QIP process and all of our projects that are part of this very high impact. And I'll toss it back now.
Thanks, Michael. We can go to the next slide. All right. Angie, you got to remind me of sister friend.
Yeah.
These you? Okay.
Yeah,
Go
that's
ahead,
me.
girl.
All right. Thanks, Michael. Thanks, Jamie. So yeah, we'll talk about next steps for these next couple of slides. You can go ahead and stay on that slide for a second, Octavio, on slide 19. So I'm just going to talk about some stuff for a second. So PCN 1502 makes it clear that, there are expectations for us at CQM is to apply a methodology for quality improvement. And we'll continue to use the model for improvement as our defined methodology for linkage to care project. So we're going to take a look at the MFI, the Model for Improvement, and identify next steps between now and our webinar in June that we'll be working on. So next slide, please. So when we were working with the Model for Improvement, we always want to start with these 3 questions. What are we trying to accomplish? How will we know that a change is an improvement? And what change can we make that will result in an improvement? So we follow these 3 questions with PDSA cycles. And the PDSA cycles can inform and modify strategic answers. The questions plus the PDSA cycles encapsulate the QI project lifecycle that Jamie alluded to earlier. So the setting aims is part of the discovery process, setting measures is fleshed out from the discovery learnings, identifying change ideas, taking root causes into account, and testing change ideas is part of the implementation phase. Next slide, please. Additional expectations for the P phase. We like to say, plan your work and work your plan. So not only with, quality improvement, but with life, if any kind of goals you have, trying to accomplish certain tasks, a big part of that foundational piece of if it'll be successful or not is based on how well we plan. And so we really want to do a good job in this area. With the planning phase, we want to remember to ask the 3 questions. When you form your teams, you want to ask, some of these questions: who's at the table? Who needs to be consulted? Do you need to have your data staff involved, your testing staff involved, your support staff? Sometimes things go awry because we haven't planned or because we don't have the right people at the table. When we were doing some of our sub one-on-one TAs, we talked through some of the stuff and just learned, just in general, at any time, a lot of our subrecipient agencies are going through, some of our agencies are going through transitions and changes. Some people may have hired, new staff. There may be new CQM staff. There may be at any time, changes in staff. Some people are unfamiliar with CQM. Some are very established and very familiar with CQM. But they may have new team members who will be involved at this QI project who may not know a lot about CQM. So whatever your state is, whatever your status, we just do kind of expect that everyone will have completed the 3 questions and begin working on the P phase of the PDSA by the time we meet in June. Next slide, please. So additional expectations, we want for the sites to establish a SMART aim statement, and kind of really want to emphasize the SMART part. We want to make sure that, our aim statement is specific and measurable, attainable, that is relevant or realistic, and that is time phased. So I want to just mention too that, focusing on one thing. So like, we're trying to link into care, then that's going to be our focus. We don't also want our aim statement to say link to care and be virally suppressed, because that'll be virally suppressed. That would be 2 things. And we want to focus on just, one thing at a time. So we're going to really emphasize a SMART aim statement this time. And the templates are being, in GlassCubes that will help to assist in drafting your aim statement and working through the root cause analysis. So you're going to also make sure that these questions are some of the questions that will help while you're identifying those things. How would you do your discovery? What data or strategic planning and other information will you use? What root cause analysis tools are you interested in? And again, talking about the stakeholders, who's at the table, because it may not be the same team that you had for the previous project for return to care. And you may identify that we need to bring some people, from our testing site, or, like we said before in the previous slide, certainly data people. And then just keeping in mind that the RCA form will be submitted on June the 15th. And now I'm kicking it back over to Jamie.
Thank you, Angie. And just a couple of quick notes, some of the things she touched on. Angie, I love that you brought up, make sure your aim statement is just focused on one thing. It's super easy to inadvertently do that. But again, we have an aim statement template in GlassCubes to specifically help you. We can go to the next slide. All right, y'all. So we wanted to give you a preview. Speaking of GlassCubes, Michael, thank you, friend, for putting a little something in the chat ski for peeps. That's his sound. All right, so what's going to happen, right? We're going to have this call. We're going to go into breakout groups here in a moment for sort of like a deeper dive into how do you all tackle discovery and root cause analysis, because those are the big milestones we want to accomplish before June or mid-June. So we have the action plan. Again, you're going to see these. This should look familiar to folks who participated in Return to Care. What we're going to do on the action plan is, following every webinar, there are some focused questions to assist you in sort of the main concepts that that particular webinar was designed to address. But there's also blank spaces because we don't want to be too prescriptive. But this action plan, what makes it different? This is like, what are the next critical steps that need to happen? This is not your PDSA. This is not that comprehensive, like what all is involved in the planning. It's more like quick wins, concrete moves, just what needs to be accomplished first. Your action plan will have you upload that to GlassCubes. We've got the GlassCubes pathway down here at the bottom of the slide deck, and you're going to see the GlassCubes pathway built into a lot of these forms as well, just for quick upload and for ease for you all. Let's see. We also have our PDSA worksheet. This is the worksheet that Miss Angie, Coach Jones in the house, has totally zhushed up for you all. So we have a nice logo and we have some nice added features, right? But your PDSA is that discrete cycle. So for the things in the P, that's where all that information is going to go, right? And then root cause analysis, we just want to see, like, what tool did you use? Did you use a fishbone diagram like what we did in ECC? Maybe you want to use a driver diagram. What's the stuff that will facilitate your linkage project? But we have a specific question. So this root cause analysis form, this is the only one and only time you'll fill this out and do this, right? Because you can continue to go back to your root cause tool throughout the course of your project, but we just want to see it once. So instead of you all submitting this PDSA worksheet, plus that really sort of comprehensive Excel document that followed your whole QIP lifecycle, we don't want to ask you for the same thing in 5 places. So that's why we've kind of consolidated. You'll no longer use that Excel form that had your aim statement, your drivers, your data, your outcomes, and your narrative, because we know we see that information in other spaces. So all of these forms have been uploaded to GlassCubes. And holler at Angie or I if you have any questions about them. Next slide, please. So there's a lot of intersections. We've spent the day talking about the QIP lifecycle, and we've spent the day talking about intersections of this linkage QIP with rapid start efforts, but there's so many other touch points. So let's think about the organizational assessment. Perfect. So this is going to be year 2 of the official OA season for subrecipients. And prior to that, we had a year of just piloting it. So keep in mind that quality improvement projects are one of the domains in the organizational assessment. And we start the OA process sometime around June, and it usually takes us about 4 months to get to everybody. I know we have David Kim and some other folks from the AA who are our PMs, so we welcome you. And so this assessment helps us as the AA work with the program side of the house to sort of share where are folks at and what are they doing. So when you think of the QI domain on this organizational assessment, remember a score of 3 is where we want to be. And above that's better, below that is just an area of opportunity, right? No shame in the game. It's a guide, it's not a grade. So look back at your OA. Where did you land in that QIP domain? Did you score 3 or less, right? You want to have a 3 or more. And so participation in this webinar, utilizing the tools and the templates we give you, these are resources to get you there and to sort of give you the capacity or tools and allow you just to focus on the process, just focus on moving yourself and your teams through the process. There's QI initiatives. Are these based on ongoing analysis of data, right? This is where your discovery process can show up. Is your QI effort focused on process of care using official method? PCN 1502 says, look, child, we're giving you lots of money from the federal government. It's not the wild, wild west. You've got to follow a prescribed method. So in implementing the model for improvement, 3 strategic questions plus your PDSA cycle, you're going to be able to accomplish implementing a QI method. Are your QI efforts regularly documented? That helps us with your PDSA reporting form, right? Documenting what happens so we can learn from each iteration. Do you share your project with your QM committee, right? Let's hope that we can spread some of this linkage to care work, not only with folks like Tarrant County and the Rapid Start Institute and the different things Michael mentioned. We're also going to want to share them with our dishes partners, but who do you share it with, right? It could be your QM committee, but I think I saw Sylvester maybe from HSNT who is starting a CAB, and the CABs are an excellent inlet as well for key stakeholder groups. And then finally, is your QI initiative going to involve cross-departmental staff, right? So this is, for our testing sites, this might involve your STI, testing side of the house, whole other group, could be a different location, could be a different division, different floor, I don't know. For the AA, we're pushing ourselves to work with surveillance and the sort of STI stuff in-house at county. We had a great call with Dr. Huang last Friday about that. So we're challenging ourselves for that same level of integration and involvement. If you're a support funded agency, right, that could still be the folks who do the direct client reach. You might be involving some of your housing people because they find out clinical information doing things like a HOPWA intake. What was your viral load? What's your insurance? Have you been to the doctor? Right? So you might be involving new staff, but are they cross-departmental? And again, this is going to focus right on the nature of this process. So that's why in your action plan, we ask you things like, who needs to be at the table? And then like, are there some new data components? So the queries with which you pull your QIP metrics, that's going to be a little bit different. So maybe some data people don't need to be a part of the team all the time, but they need to help you right now in this planning phase. Nonetheless, it all relates back to the OA. Next slide. So I talked a little bit about how we're challenging ourselves to involve the STI clinic. But again, we're going to be, sorry for a little typo there, but we're going to be reporting to dishes as mentioned on a routine, regular basis. And I honestly think given what we were able to do, Return to Care was our first regional effort. So this is our second regional QIP. So I am confident that Dallas can emerge as a very strong AA across Texas because we've worked really hard the last 2 years to build up the infrastructure for this kind of thing. We're going to share back on those PDSA worksheets. So Angie last year, sort of behind the scenes, piloted a rubric, right? So when you send these reports, there's a standard way that she's kind of looking at them. And it keeps us accountable because I know when I used to be a quality manager in Kansas City, people would say all the time, ugh, I send a report into like the abyss and I hate it. So we've got this rubric to make sure that we're accountable for thoughtfully reviewing it and identifying TA. So we have that via the PDSAs, we have it via these action planning forms. And this information, like I said earlier, it's important so we know how to best target these webinars to be a value add in your day and 90 minutes worth your time. And then again, we can always do individualized TA. Next slide, please. Okay, y'all. Breakout time. So let me, we'll walk through the next couple of slides. Let me set the stage for what we're about to do. We can go to the next one. All right, so this is a sort of a sample of our breakouts. Breakout groups 1 and 2, those are going to be sites who are funded to do HIV or STI testing. We're actually going to merge those two just from some technical difficulties. So AHF, AIN, Cali, Parkland, HSNT, RCD, and PRISM. You, me, Oscar, Angie, and Dee will be in one breakout group. Michael is going to champion our very valuable support service folks. So if you are with ASD, legacy, or legal, you, Michael, and Regina are going to be in a breakout. And then a handful of folks are just going to stay put in the main Zoom room. So these are folks, I think Catherine Fergus is on. Thank you for joining us. We have some AETC love and representation in the house. We also have Julie and others from Dishes. We have Miranda and others from the EHE. You guys are sort of our like leverage partners and collaborators. So you're going to stick with Octavio and Julie sort of in this main Zoom room. If there are additional AA staff like David, we'll have you stay. We can go to the next slide. So that's a little bit about what you can expect. So breakouts 1 and 2, which are going to be merged anyways, these are the testing sites. So we're going to focus in on just definitely discussing how we identify and track the QIP metrics. Someone who has a new HIV diagnosis with a dual bacterial STI, and that individual gets linked within 7 days, right? Our support folks with Michael, they're going to look at where their role is, what's the skin in the game they have, right? So that this doesn't feel like, well, it's so clinical, and what do we have there? You know, we don't want you to feel that way at all. And then in the main room, like I mentioned, you're sort of some excellent points of leveraging and learning. So you'll have a guided discussion there with Octavio. Breakouts are going to last for 30 minutes. And then once that 30 minutes has taken place, we're going to all get sucked back in the main Zoom room. And then I'm going to ask the folks who are the facilitators of those breakouts to share 1 or 2 like sort of key learnings or key questions, key discussion points. Are folks clear on the plan for breakouts? Who's going to go where? I'll open up the rooms, and I've been able to assign just about everybody. Any questions about the breakout room? Are we good to go? Okay, let me just hit that. So I'm going to open all the rooms. You'll go down to the, you should start to see an invitation for a breakout room, and you can start to join. Awesome. I'm going to set a 30-minute timer. Thank you. Give me 1 second. Okay, so I'm just double checking that this main Zoom room looks good. Jonathan, you might be with somebody. Okay, cool. He's good. Okay.
No, he's still here. Oh, no, no, he's still there.
Okay, so Octavio, Jonathan, oh, there he went. All right, so you're a co-host, so you should have the ability to move anybody to a waiting room. It's great to see all you rock stars here. OP is top notch. So I'm gonna go to my breakout room, and we'll come back at 12:20 or 11:20 Central.
Thank you, Jamie.
Okay, crew. Thank you for giving me just a moment to double check. This is a full house. I want to really appreciate and say thank you to everyone who had a widespread for this QIP kickoff with their folks. We would absolutely love to see you on camera if possible. If not, you know, or you have maybe patients or clients or other folks in your workspace, I definitely understand the need for privacy. We do have Dr. Oscar Salinas on, and Oscar, I know you had some technical difficulties joining, but I didn't know if you wanted to just say a quick word of welcome before we get started in our breakout conversation. And you're on your phone, so hopefully you can unmute. If not, we have the chat feature. All right, folks. So Angie, do you feel comfortable set for things like notes?
Yeah.
Okay, awesome, cool. All right, so this breakout group, y'all, you are the folks who are funded and you're able to do HIV STI testing, you know, whether or not, like I said, that's maybe between different teams at your organization, that's fine. But first we wanna just kind of get a quick picture. How does testing work at your organization when it comes to like STI testing? And I wanna provide some examples. So of course, some people come in and they get their STI tests and HIVs at the same time, right? So that order set, that lab draw might be on the same day. But in other instances, someone maybe comes in for their syphilis, chlamydia, gonorrhea, right? And a positive test there sort of prompts an HIV test, right? So then the HIV test happens later. Maybe you work at an organization where you have like an emergency room. So somebody tests positive for HIV in the ER, and the STI panel is then ordered after that. We just want to get sort of a breakdown to your best understanding. How does your HIV space and your STI testing space intersect? And I know we've got AHF, we've got Parkland, we've got HSMT, we have RCD, and we have Cali. We have a lot of folks on the line. So whoever wants to jump in, go right ahead.
Hi, good morning, everyone. This is Candace from AHF. For us in Dallas County, we actually have a wellness clinic where we are doing the rapid HIV testing along with the STI testing as well. So it all happens within the same walk-in appointment, and the draws are all done at the same time.
So Candace,
Awesome.
I'm sorry, real quick, Candace, when you say rapid HIV and you send rapid STI testing too, is that a urine test or what type of test is that?
So first we are doing rapid HIV testing, and then from there, since it is a preliminary positive, we do a confirmatory. So we actually draw labs. And then for the STI testing, we are doing anal swabs. We are also doing urine tests, but then also we're doing lab draws as well.
Awesome. Thank you,
Oh, thank
Candace.
you.
Great to
You're
have you. Other folks, go ahead, Kim.
Yes, well, we have the rapid tests that we do on Fridays at 2 locations. But we also have testing, I believe last year, and at our women's center, we had they do this test. I'm sorry, it's Monday morning.
It's okay.
They do testing for the prenatal patients, and we did have one last year that we referred over to Parkland because she tested positive. And then we have others that are here for different reasons, and they do the STI testing, and a lot of times that will also include the HIV. And I was talking to one of our ID providers Friday and telling her about this project, and she said, yeah, most of the ones, you know, when they're initially tested, it coincides with an STI. So she was really excited to hear more information about this.
Awesome. Well, I'm glad that brings someone in, and you can champion. It's easier to champion enthusiasm than roll with resistance. So
yeah. And then like new ID patients that were diagnosed elsewhere, a lot of times unless they had the STI testing where they were diagnosed, they'll include that in their initial panel.
mm-hmm. Cool. And you bring up something interesting. I do want to give space to Cali or RCD or Parkland if you're like, yep, same deal for us, only it's across 3 sites, or I want to give you all space to talk a little bit about your HIV and STI testing. And then I have a follow-up question. Hey, Doug.
Great. Thanks, Jamie. Hey, this is Jonathan.
Hey,
yeah, so we have really robust testing program. We have 2 testing counselors that are for community point of care testing. So we work with a lot of partners in the community at various events, including Dallas County. And we're looking to expand that in different areas this year. We did increase our testing goal 25% to 1,000 across 2 testers. We are on target for that. And then for our ED and community sites across DFW area, we have a best practice alert that's firing for HIV. So we are targeted to do 27,000 tests this year in the specific zip codes for our community health needs assessment, which is internal to Parkland, which then will equate to around 100,000 tests for HIV. We are also excited to, a new development is we were able to add our testing counselors to the standing orders internal to Parkland to be able to order STIs to better support our CHWs and STI clinic.
Yeah, so love that. We had a lot of EMR talk. So so BPA best practice alert. Can you remind me what you were saying about that, Jonathan?
Yeah, so we worked really hard to get it to fire in our EHR based on risk and the CDC guidelines for risk, that they automatically get an HIV test if they interact with any of our community oriented sites. So we have 100+ of those in various disciplines across Dallas County, as well as our ED, which has a large volume, of course. And so they get all the providers get a notice saying, okay, this patient needs an HIV test, and they will automatically do that unless they opt out. So that's been quite successful to getting large numbers of tests done, and then of course linking those patients in with reactive results.
Awesome, thank you. You know, and I'm actually working with a clinic in Milwaukee, Wisconsin, and they're trying to increase their HIV testing. And so getting standing orders, right, making it part of true protocol, like written true protocol, making sure the standing order, like for example, Candace, you made a great point with your STI testing. You know, it's not, you know, one site. I think we're going to learn a lot in this QIP that maybe we don't do testing exactly how we thought we would, or exactly how the process is maybe on paper. And that might be, you know, staff education or comfortability, you know, who really knows? We might uncover that, and that's okay. Part of this is to learn. But, you know, I really appreciate, Jonathan, you mentioning the different pieces like standing orders or a best practice alert within your EMR to help prompt you. And that's something that there's this clinic and they're an FQHC, but they didn't have that for HIV testing. So, you know, there might be sites on here who part of this QI project, we can explore how do you revisit your standing orders, or how do you make those best practice alerts work for you in your EMR systems. Really great point of interest. But
Hey,
I think, oh, go ahead.
I'm sorry, real quick. I think Oscar's saying he's trying to say something. I think he's
Oh.
muted. Can you unmute him and see if we
Yeah.
can? Okay.
Of course. Of course. Sorry, Dr. Salinas. I'm asking you to unmute. Oh, there you go. Hey, boss.
Okay. Finally, I'm convinced that I'm a robot now. I dialed 20-something plus times to register, and send me to the same link that confirmed that you're not a robot. You're not a robot. But I'm a robot now. But no, I mean in the details that Jonathan, I think he was talking about the testing piece. When you do testing outside and so someone is testing, well, first of all, I would like to know what kind of STD testing you are doing out. It is a community testing urine only, which is gonna be just chlamydia and gonorrhea. And what about syphilis? Syphilis, you do the finger prick, or you send or you refer that for syphilis. And the same with I couldn't catch who was talking on the previous participation, but the same way when you see STD testing, some Cali clinic was doing testing just on 2 STDs, which basically was in urine, chlamydia and gonorrhea, but they were not doing syphilis. In this case, we want to have the the clarity that you are doing the STD panel component with 3. The 3 that we want to follow is chlamydia, syphilis, and gonorrhea. So, I mean, do you mind to clarify that? And would that happen outside? But if that happened inside in the clinic, the reflex process happened just with the gonorrhea, just with the syphilis, just with the chlamydia, or just with the HIV? What's the process that you have inside the lab? If you know it. If you don't, it's a homework maybe. Okay.
Yeah, part of it's definitely homework, but we are doing all 3, syphilis, gonorrhea, and chlamydia. And that is part of the lab draw that the testing counselors are ordering.
Thanks, Jonathan. Oscar, you made a great point, right? So one of the concrete takeaways is if we're looking at dual diagnosis with a bacterial STI, that includes syphilis, chlamydia, or gonorrhea. So again, what are the testing processes? How's that taking place? Is one of them sort of reflective of another, and things like that. I want to give Del and Norma the chance to weigh in, and then we can kind of continue the discussion. Go ahead, Del.
Okay, good morning. Resource Center has a large prevention program that includes HIV testing and STI testing. So that's, of course, done through a prevention unit, not a treatment program that I'm involved with. But the people who test positive are either referred to, well, definitely they're referred to a medical clinic, either ours or some other location that's good for them, et cetera. So we do community testing, we do rapid testing, and our preliminary positives are referred to Dallas County for verification. And then we wait a while to get that back. So that's a big interest to me about the rapid start and that issue, but that's a different topic at the moment. We do STI testing for cause or by request. All of our HIV, a lot of our HIV testing is done separately from STI testing, but I have a lot to learn about our the exact protocols that go on in our testing program, because at the moment I'm not greatly tied into that. Let's see, there was something else I wanted to say about how we do. Our medical clinic, of course, does STI testing too. So that's about it.
Well, thanks, Del. And you bring up a great point. You know, this might be bringing in some of the folks from like the prevention and testing teams. So one of the other pieces you can think about over the course of these QIP webinars is what kind of technical assistance can we do to help, you know, maybe there's a certain foundation of quality or QI knowledge, right, that these folks haven't been exposed to yet, but it would help them sort of get the why behind what's happening and what their role in this larger process is. So, you know, oh, go ahead.
We will definitely be pulling in some of the prevention director or whoever he wants to designate into this process. So, I mean, we're already working with the prevention department to identify potential patients or clients for our Ryan White programs.
Mm-hmm.
And you know, as far as this quality improvement project, we'll definitely have involvement with our prevention program. So
that's exciting. Casey or Norma, do you want to weigh in on anything from the Cali perspective?
Sure. This is Norma. Hi, good morning.
Hi.
So we are a designated STI testing clinic. We get funded directly from the state to do STI testing, so people will come in for that. It can include HIV testing. I would need to find out a little bit more about whether that's something that's done as part of a packet or whether that's done based on some type of positive results, but we do it. We also do outreach into the community, and that would be rapid HIV testing. And we also do STI testing as part of routine HIV clinical care.
Great, great.
What we can monitor, what we currently monitor is obviously, well, not obviously, syphilis, chlamydia, gonorrhea, and HIV. That's monitored in the well, that's noted, put into the EMR, and then downloaded to CareWare. So we can pull those stats on those STIs.
Nice. Norma, girl, we got to put you on the payroll. You're queuing me up for the next piece I wanted to talk about.
Okay, I'm there for you.
She says, let me get you my social. All right, I'm going to share my screen real quick because I'm a visual person. We heard from a lot of our leadership or maybe prevention and testing supervisors, but I want to give us a chance to talk about the data. And Norma, you mentioned something really fabulous about being able to query from your system all three of those STI tests as well as the HIV test. So let me pull up for folks, just as a reminder, what you all as sites that do testing, what your QIP metric is, and I'll make this a little bit bigger. So just to review, you're going to be reporting on a quarterly basis, and first report is June 15th. So there's about 6 weeks, you know, for folks to have conversations. How does this work internally? How is this documented in the EMR? How would we query this information? So we have some time. And if you get to that process and you're like, oh man, James, this is going to take a minute, just reach out. We anticipate there might be some bumps in the road because there's multiple factors happening, right? We're looking at someone 18 and up, right? Newly diagnosed HIV. We're talking about your new HIV positives. and they have a dual bacterial STI diagnosis. So what we've been talking a lot about is when we say dual, do we mean literally same day, same order set, same sampling sent to the lab and it comes back? Yes, of course. But what we're going to do is kind of do like a plus or minus 30 days. So let me focus this on a question. We want to talk about the pros and cons of that. And we can revise this, this wording a little bit more if that assists. And folks, you can see my screen, right? Yeah, okay. So you're looking at people who have dual HIV and bacterial STI diagnosis. It could be syphilis, chlamydia, gonorrhea in the last quarter. So first quarter is March 1 through end of May. So out of the folks that you saw, who would meet that? And then of those folks, how many had verified medical care within 7 days of their HIV diagnosis? Because again, we're focused on new HIV diagnosis who also have the bacterial STI. So I might test positive on April 1st for HIV. So you're going to look at my diagnosis date, and that's where that 7-day window kicks in. And then the other factor you're looking for me, Jamie, is like, let's say I was diagnosed April 1st. Do I have a bacterial STI positive test within 30 days of my HIV test? Does that make sense to folks? Give me a thumbs up. Give me an unmute.
Yeah, this is Dell. Do you mean 30 days before or after?
So the
HIV
yeah.
test or after?
So the STI diagnosis, that we can do a 30-day window either before or after.
Okay.
Yeah.
Thank
You betcha. But we sure know from past performance measures like medical visit frequency or annual retention and care, when you start to run data based on this date and that date and how much time in between, that can be difficult, right? That can be difficult for our data folks. So we just want to give some space to talk about what do you anticipate are maybe some primary questions that you want to take back in terms of, can we actually report this? Or what do we need to learn? Or what do we need to make progress toward in our own understanding and also in our data query?
This is Dell again, Jamie, with Resource Center. Can you go over again what you first said about the dual diagnosis? It's dual diagnosis sounds like you're doing both of those diagnoses on the same day, but I think you said not necessarily. Can you just go over that again, please?
Yeah, so we do say dual diagnosis, but then in some of our conversations, we've realized that there might be folks where the two tests didn't occur actually on the same day. But for transmission purposes and from a public health perspective, we know that that bacterial STI, might increase risk of acquiring HIV or, things like that. So we wanted to give folks the space, right? We didn't want to be so narrowly tailored that, in practice, how many occur on the same day versus, I think maybe it was Kim. So if HSNT gets a new positive, you are newly diagnosed with HIV, you got diagnosed on April 20th, but we don't have any information on an STI panel. Let's order you one, right? Or Dell, you said we get our rapids, we send them to the county for the confirmatory. So if the confirmatory test date, let's say that's April 24th for me, I tested with you, and then I got my confirmatory at the county, that's April 24th. I might have come to you and done my rapid HIV and my STI. So now my STI, you might have my positive STI, but it's taken the county 2 weeks to get the confirmatory to you. So do you see how those are instances where the dates don't literally match up, but we don't want to necessarily eliminate being able to track those individuals? Does that answer your question?
It does, but I need a little more help. So is the parameter reading this, both of those things happen in the same quarter?
Absolutely.
Okay.
Yep. Yep. So if I had, yeah, right. So again, this is just where some things with dates. So I think a step for us is to get more descriptive and more clear with this definition. Because again, we had to learn in this process sort of how does testing actually work? And sometimes it's all on the same day, but sometimes it's not. So we didn't want to
Yeah.
leave that out. Any additional, oh, go ahead. Mhm.
Yeah, one last thought. What
Mhm.
happens, so you have a client, patient, who tests HIV positive, but does not get STI testing. That person just falls out of this whole scenario, right? Okay,
So for the purpose of you reporting your QI project to us, yes.
okay.
Now, if you internally say, hey, rapid start 7 days, you still can follow that person, right? Which is, what's probably going to happen. But in
Yeah, of
terms of,
course.
but in terms of pulling them for the metrics that you share with us, no. Great question. Go ahead, Kim.
Okay, I just want to confirm the diagnosis date, because you said the 7-day window starts when they're diagnosed, and that's the result date of the confirmatory test, not the rapid test or not a panel. It is a confirmatory test.
Yeah, confirmatory HIV. Mhm.
Okay, I just wanted to clarify. Thank you.
You got it, girl. Do we
Yeah.
have, yes, hey, Norma.
Hey, okay, this is probably an incredibly dumb question, but conventionally, no, it might really be dumb. Conventionally, when we pull performance measures, it's 12 months. Is that still what we're doing? Or are we doing just, that gets the quarter, the most recent quarter, but it goes 12 months back. So you're asking for quarters here. Are you looking just for quarters, or are you looking for a 12 months performance measure?
Great question. This is just quarters. In my last quarter, who came in with a new HIV diagnosis and had a co-occurring STI, plus or minus 30 days of the HIV confirmatory test date? So we're only looking at quarters. And so one of the things we're calling this our QIP metrics, because they are a quarter look back versus your performance measures for like OAHS or APA, which is looking at annual retention or viral load, and that is a 12-month look back. So yes, for your quantitative performance measures, that's always a 12-month measurement period. But for the QIP metrics, we're just trying to look at, hey, this quarter, how did we do? What happened last quarter with the new people? And right now, that's all we're gonna bite off for right now.
I'm pretty sure CareWare can do that. I
Okay.
just have never done a 3-month measure before,
Okay.
but I'll play around with it.
Well, check it out. Let us know. That's important to bring up. That's an important consideration. Are our systems and our data queries so used to 12-month lookbacks? Is there any kind of customization or filter of the measurement period or something that you all would be doing, or the folks who run your data? These are important considerations. So definitely welcome that. We have about 3 minutes remaining. So I just want to check in with the group. I think we've all talked about, different stuff after we leave today. The AA is going to want to do on our end, and things you want to maybe do, better understand your processes or the way, standing orders or things happen in your EMR, maybe understand, can you pull your data in certain ways? Maybe talk to your testing and prevention folks a little bit more, tell them a little bit about this. But in terms of working through discovery and root cause analysis, and setting an aim statement, those are big expectations. Do folks have questions about that or concerns as it relates to this QIP? Okay, go ahead, Del.
This is Del. So how soon will the slide deck be put in GlassCubes, and how soon?
I would like that to happen into business tomorrow. We can send an email message out But we'll also have the recording, and then we have some of the tools and templates are up. So I would say into business tomorrow, and we can send an email message out so folks know.
Thank you.
You got it. All right, I just want to give anyone the chance who's maybe not been able to talk. Astrid, Sandra, Casey or Joni, anyone else, Piper, want to weigh in on sort of how you're feeling, what you look forward to, what you're concerned about? You know, it's an open floor, open space.
Hi, Jamie, this is Sandra. As discussed last week with our TA, it's definitely new grounds for quality management. But I'm glad we had Candace on the call to explain what happens on the wellness side. And we will definitely have a lot of internal meetings to figure out how the data systems can talk to each other for us to be able to have this in one report. And we're looking forward to those conversations.
Thanks, Sandra. And I
I'll jump
appreciate.
in.
Go ahead,
Yeah.
Piper.
Sorry, I'll just jump in to say that for us to not get bogged down, this will be new territory for us as well, Sandra, so you're not alone. We know we have our STI in a panel when the client comes into our care. So we'll still be pushing for connecting all of our clients newly diagnosed with HIV within us and then pushing the gap to 7 days, trying to just really make it rapid start. And we'll just stay tuned, right? Like we want to get a baseline understanding of what our positivity is that shares the dual diagnosis. And then from there kind of learn where the gaps are. Because right now we know that we can see both, but we're just so immediately focused on linking HIV care and then treating whatever they have, right?
Mhm.
And STI is one of the components, but it'll be nice to kind of just look and make sure. It's always a good QA tool to make sure our STI partners, you know, there are COPCs that are testing for STIs, that they're really connecting that to HIV testing and then vice versa. So it'll be a learning curve for us as well.
Thanks, Piper. I appreciate that. That's a great comment to close us out. There's the components of the STI panel to this. Then there's just a component of the rapid start for the new HIV diagnosis, 7 days, right? So there are some layers to this. I'm going to close the breakout room and we're going to all go back to the main Zoom.
Shot that we're not ready, we don't have yet.
Thank you so much, Julie. And what are some of the challenges before we get percent? Oh, we're in the main one. What are some of the challenges that you're facing right now? I know there are some that have been mentioned, but like data collection or the accuracy of the data and how it's being collected. What are some of the challenges?
I think some of the providers are not aware that they don't need to wait for the genophenotype labs to come back before they start medication. That's what we're hearing in some of the rural areas. So we're doing a lot of teaching. So that's been a challenge because they want to wait for those labs. So that kind of defeats the rapid start or delays it. We know the challenge of the waiting for THMP approval, but those of the areas with EHE funding, you can have a pot of money to buy the ARVs and have them in the clinic or use the sample starter packs, or there's lots of options.
Yeah, this is Dell Wilson. If I may ask a question of Julie. Dell Wilson with Resource Center. Julie, so without waiting for the genotype, what's the recommendation? I want to make sure I'm clear. What's the recommendation of what to start someone on?
I have to look that up, but I can definitely send you in an email. I have your contact information. I think I know, but I want to double check. I don't want to be wrong in front of this big group. But there are some clear guidelines of what to start while you're waiting for the test that are really safe, that do not have any evidence of resistance build up in the timing before you're going to get those labs back.
Okay,
So
well, I want to make sure I know too. So thank you, Julie.
Thank you, Del.
Well, I want to say it sounds like a lively conversation and already an opportunity for some sharing. So again, we really appreciate Julie, our AETC peeps, our other dishes folks and AA staff being here to lend support to the funded agencies to do the good work. So let's do a quick recap. So we have about 7 minutes left. We don't have a ton of slides, but we do have a few just to kind of wrap us up. But I want to maybe hear from, we'll do Michael's breakout, maybe one, big sticking point or question. So we'll do Michael, Octavio, and then I'll wrap up.
Thanks so much, Jamie. Now, I have some notes. I don't know, Regina, if you want to, go first and make a comment what you thought was interesting.
Oh, no, go ahead, Michael. Thank you.
Yeah. So all of our sites in the social service group have standard intakes for all their clients. I think that the important piece here was just to note that the number of new cases being reported will be low, which is important and was by design on purpose. And that the request was that we work proactively each quarter to reach out to see if there are, at the midpoint in between submissions, if there are any TA needs. And I think that that's really great, and just a reminder to be collaborative in terms of the way that we champion the project. The last piece would be that technical assistance that would be important would be understanding who's servicing who, how, when, and where. So we're talking about creating some work plans and also some use case trials or case studies, or basically a discussion where we use test data or a test person and how we work together on them.
Because it's such a helpful learning tool. And then it's also sort of data and qualitative storytelling. So thank you. And thank you for the push for proactive reach out. So no one feels like, ugh, right, when it's submission time. OP, go ahead.
Thank you, Jamie. So I'm sure it was the same case in all the breakout rooms. We needed more time, right? But it was a very engaging discussion. I do want to thank everyone in the panel, and Julie, of course, for note taking and your participation as well. So one of the things that came out, the topics that emerged was, of course, the reason why we we all met. It's defining, how soon someone needs to be linked to care. Also, some of the challenges that come along with it to see if the agency, of course, has the capacity to do that. And as well as, every agency or every jurisdiction, it's different. They have their own reason why they do things, and also to consider that as these being reasons for silos, and of course how to approach them. Then I will turn it out for you, Julie. I know you were doing notes, you were taking notes as well. I don't know if there's anything else that you would want to add.
In the chat, you're muted, Julie, if you want to talk, but she did drop a rapid start within 72 hours, some information there about recommended regimens and other pieces like financial assistance. Julie, you go ahead.
Sure, this one's straight out of Austin. It's a fast track city deliverable. They're working in a collaborative, I forget with which group, but this is from the Austin team. We have another similar one from San Antonio that we've been sharing. They're very similar, but these have been vetted by physicians. Of course, Del, we recommend that you talk to your clinicians before, making big changes, but this is a very current version. Thank you.
Thank you. And Michael put a little love as well in the chat, so thanks. Just Angie, do you want to just quickly share a couple of discussion points that came out from our group, which was focused on the sites that do HIV and STI testing? Go ahead, Angie.
Yeah, I think a lot of people doing things a lot of different ways in the clinic, in the field, in different places, and some will have to go back and find out kind of, what the protocol is for if someone's tested first for STI and then they got HIV test versus, HIV test, and then doing the STI pieces. So I think there's a lot of things that people will be asking their home agencies about, and then letting us know, and then we'll be doing, some of the same, because I don't know if we've ever really sat down and talked about all this, so we probably don't know what the flow chart looks like. And I think we'll all have a better understanding in the next couple of days once we find out exactly what's happening at our different agencies. Did you want to add something, Jamie?
No, I think you did a great job. And, I would just put another part of TA, if it's helpful to you and your teams to assist with creating process maps and flow charts or workflows and kind of having them like nicely put together to help, unbundle, unpeel this onion. That's absolutely 100% a type of TA support that we can do. And those kind of materials, we can create those process maps and flow charts PDF form or JPEG form so that they're easy for you to share, whether you have to do a presentation or a Word doc or policy update or things like that. So we are in the home stretch, y'all. Michael started singing and so, now I am too. And I apologize, I'm getting over a cold, so it's probably not the best sound. So we did a little bit of a debrief from our breakout groups, and I appreciate everyone's thoughtful conversation. Just as a reminder, the consultant team, myself, Octavio, Michael, and then Frank Thompson, who's pulled in not for subrecipient coaching, but for some executive coaching at the AA across funding streams. Fantastic. Us consultants are going to try and make an in-person trip to Dallas. It might be in June, it might be in August, so stay tuned. One of those QIP webinars might be something we do in person, and then we can leverage our time there to maybe meet with you and provide some TA additionally. But this is what we have on deck with action periods in between. So I just want to send that reminder to folks and definitely spread a word of thanks. Go ahead.
I'm sorry, before you go, because Oscar's had lots of problems with technical difficulties today. So if he wants to jump on and just give a word of thanks or say something before we wind out, is that okay?
Absolutely. Go ahead, Oscar. Close us out.
Thank you so much, Dan. You're always detail oriented. I like that feature. That characteristic is very unique. And I want to thank you, though. You are the star guy. I mean, so recipients are the ones who make the troopers of this project. So we want to support you in any circumstances. And I want to thank you, our coaches, for this cohesive work, including the HE. This is a huge project that's gonna be exponentially way humongous after incorporating the HE. Thank you, Octavio Posada, and as usual, Michael, his patience, his diligence, his wise wisdom, and Jamie is driving this boat. And I want to thank you guys for all the things you do. And well, technology is always could be betrayed. So, but I want to enjoy this process, and we start thinking about it. I'm the one to promote that. Please enjoy it. If you feel like this is rough, this is bitter, forget it. You're not doing it right, because you have to be fun, have to be part of the game, part of the characteristics. And it takes a lot of communication within your agency, IT, who's coming 30 days, register, who's going to follow those people who tested positive after being HIV positive and have an STD, who's following them. You have to connect your IT department and include your network connection on notification of, okay, this is HIV positive, but came back a week later with an STD. So each part of the denominator, yes, no, questions you may have, we have lines open, whatever number you want, whatever smoke signal. We want to keep the communication completely open. You can email any of us, call us directly, or for any questions that you have. And thanks again for being here. It's Monday. Thank you.
Thank you, Dr. Salinas. We echo that. There's layers to this. Let's take our time. Let's go through those 3 strategic questions in part of the P phase. Reach out. We'll have materials in GlassCubes, and we'll circulate an email when you know it's out there. We couldn't do this without you. And again, special thanks to our additional AA staff, our state partners, our AETC partners for joining us today. We look forward to following up soon. Have a fabulous Monday and a fabulous week.
Are we doing a quick evaluation before we sign off?
Oh, you know what? Thank you, Angie.
You're welcome.
We can launch this. If you do have to go, I understand.
There she goes. He's working it.
Thank you. So
and thanks, Regina. Thanks, Regina.
Yeah.
Too. Absolutely.
we might not, folks might not have time. I forgot about that. I apologize. So did the poll should have launched. We have 5 quick questions, just assessing, did this webinar and discussions meet your expectations from strongly agree to disagree? We have our little Goldilocks. Was it too long, too short, or just right? Did you feel there were opportunities for you to share and participate in the webinar? Again, anywhere from too little to too much or no opinion. How clear are the AA's expectations of what your agency is going to focus on between now and June during our action period? And then the last question, I know who to contact if I have questions. So we appreciate you sticking around and taking this. We have 17 of 19, 18 of 19. I'm going to end the poll and share results. And with that, we'll bid everyone a fabulous day. Thanks for sticking around the extra 3 minutes.
Thanks, everybody.
Thank you. Thanks, Piper. Thank you, Angie,
Thank
for
you,
having
guys.
my back there. I do have to run to another call, so I'm going to go ahead and hop off. Okay. Great work
Bye,
today.
everyone.
Rock and roll. Thank you.